Hello, everyone, and thank you so very much for your patience with us today. Welcome to the Essential Substance Abuse Skills webinar series. I am Donna Dorothy, and I will be administering today's webinar. Today, Denise Casillas will be speaking on clinical evaluation assessment. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the locations of the 4 national focus center ATTCs. To learn more about our center, the network, or your regional center, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam that you seek additional preparatory help and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, May 21st, when Denise Casillas will be returning to present clinical evaluation treatment planning. We also offer the American Indian and Alaska Native Behavioral Health webinar series each month. The next session in this series will be held on April 7th from 1 to 2 p.m. Eastern Time, when Wendy Kahlberg will present an overview of fetal alcohol spectrum disorders, what we are learning about diagnosis and intervention. For more information on our webinar series, you can contact Kate Thrams at the email address or phone number provided on this slide. Our center is a NAADAC certified educational provider, and we'd be happy to provide you with CEHs. The cost is $10 to do so. The CEH request form is available for download in the Files pod in the webinar screen. If you choose to download a file, a new tab will be opened in your browser, and you will have to click on the webinar window to return to view the webinar. If you are unable to download the documents for the webinar, please contact me using the information on the slide. Immediately following today's webinar, you will be redirected to our GPRA evaluation. We invite you to participate in this brief online customer survey. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our survey. Before we start today's session, I'd like to go over a few instructions for the Adobe Connect system. To view the presentation in full screen mode, click on the full screen button at the top right corner of the presentation pod. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Denise Casillas. Ms. Casillas is the director of the Four Bands Healing Center, which is a substance abuse treatment program for her tribe, the Cheyenne River Sioux. Ms. Casillas, thank you so much for joining us and for sharing your expertise with us today. And I will pass things over to you at this time.
Thank you, Dorothy, and good morning, everybody, or good afternoon, actually, now for some of us. I apologize, too, for the technical difficulties that we experienced this morning, but, you know, sometimes these things can't be helped, so thank you for your patience, and we'll get started. I also want to say that, you know, if you guys are needing to ask any questions, I don't mind stopping and answering. Otherwise, you know, just we can all leave your questions and maybe we can answer them at the end too. It doesn't matter. So the first thing that we take a look at is the clinical evaluation goals when we do an assessment. So we define the assessment process. The goals of this presentation are we're going to define the assessment process. We're going to identify assessment instruments. We're going to define the DSM-4-TR criteria for substance abuse and dependence, the specifiers, and the multi-axial assessment. And currently, you know, because this particular presentation still uses the DSM-4-TR, you know, we haven't updated it to the DSM-5 yet. So we'll move to that. We'll move to that, you know, as time, you know, as far as the time frame for the next cycle. Then we're going to describe the ASAM levels of care and diagnostic and the dimensional criteria. So what is an assessment? An assessment is the systematic process of interaction with an individual to observe, elicit, and subsequently assemble the relevant information required to deal with his or her case, both immediately and for the foreseeable future. You know, doing an assessment is so important in our field, especially because we do send folks to treatment and psych units on a regular basis due to both the mental health and the substance abuse issues that we encounter. The sequential assessment, within that, then we do the screening, the problem assessment, and then, of course, the personal assessment. You know, when we take a good look at the extent of the information that overall it takes, you know, with the screening, the problem assessment, and the personal assessment, as one moves from screening to problem assessment to personal assessment, the extent of information developed is greater, but the costs of the assessment are also greater. So performing an assessment sequentially ensures that further information is necessary and thus justifies its increased cost. So it, you know, as it's determined where we send folks, this really helps us as far as costs and the amount of, the length of stay, all of that stuff, because for a lot of folks that we send out, we maybe place them in a psych unit to initially stabilize them, and then they move on into a treatment program. So the information is sought along 3 dimensions. We use the use of alcohol and drugs, the signs and symptoms of alcohol and drug use, and then the consequences of alcohol and drug use. So we really take a good look at all these different levels of substance abuse. A brief process this is the content of screening, a brief process that answers 2 questions: whether an alcohol and or a drug problem is present, and if so, whether or not we need to intervene or do some specialized treatment for the client. So in a problem assessment, we definitely examine what's attributable to the alcohol or the drug consumption. So like we take a good look at what are some of the, you know, the factors that have added to, you know, this whole issue. So for example, a recent breakup, you know, marriage, maybe loss of a job, maybe not able to have a job. You know, there's so many different levels of it, you know, poverty, just location. The 3 techniques that we use are the retrospective method, the prospective method, and then, of course, laboratory determinations. So the content of problem assessment is, are there any what kind of signs or symptoms of alcohol or drug use that's available? So, you know, we use the DSM-4 criteria and any kind of self-report questionnaires, and, you know, I'll go through a lot of those here in a bit. Currently, the slide you see is the alcohol equivalencies and drinking. So, you know, a glass of wine, maybe 4 ounces, there's about 12% alcohol in this glass of wine. A can of beer or bottle of beer, which is about 12 ounces, is about 4% of alcohol by volume. Shot glass with the distilled spirits, like say 1.25 ounce of whiskey or other hard liquor, this has 40% alcohol by volume, or it's basically 80 proof. A bottle of a wine cooler, which is 12 ounces, is about 4% of alcohol. So as you can see, the difference between, you know, the amount of alcohol per type of liquor. And, you know, so when you're actually doing your assessment and determining what they drank and how long they've drank, that's a really key factor in this overall assessment process. So when it comes to the consequences of alcohol and or drug use, there's several types of screens that we use. You know, there's the Michigan, or the MAST, or the DAST, which is now called the Drug Use Questionnaire, or the Alcohol Use Inventory, or the Audit. Anybody who uses AccuCare, you're using the Addiction Severity Index, the ASI. I'm not sure, but I think the adolescent version of the AccuCare is the CASI, the Child Addiction Severity Index. So within the content of the personal assessment, we examine problems to determine, you know, how they are related to the problem. So, for example, we take a look at their medical use, their medical status, any psychiatric status, vocational issues, personal problems, sexual problems, social support, family structure, and the need for recovery support. And this, when you actually do an assessment, it can be a lengthy process, and sometimes, you know, needs to be broken down into, you know, 1 or 2 sessions, or, you know, however long it takes for them to get through everything. And a lot of people just can't sit still for that long, so it's, you know, you need to be patient. We're going to continue on with the personal assessment. We need to take a look at, you know, how do they spend their leisure time? Are they exercising? Do they have any hobbies? You know, any kind of demographics. Family history is very important, especially in the substance abuse and use category. Prior treatment history, if they've never had treatment versus how many times have they gone through treatment. Their level of intelligence, their cognitive functioning, their personality, the treatment goals. You know, do they have any kind of insight into their behavior? Most of the time, folks that I work with, a lot of times they have zero insight and totally are in denial that they have an addiction problem, even when the UA shows that there is some drugs on board. We got the social stability, the situational factors, and spirituality. Situational factors could mean, are they homeless? You know, are they living with family? Do they have their children? Do they have, you know, I mean, there's so many different levels to this. The overview of the assessment process. So there's 5 steps that we definitely take a look at, and that is the detection, the classification, a functional assessment, a functional analysis, treatment planning, and recovery capital. So within the detection, the clients are usually identified that have a potential problem. On Shine River, a majority of the clients that come to us come through the court system. Family member, spouse, relative does an involuntary commitment order petition to get them to go to treatment. So really what happens is A lot of these folks do not want to go to treatment, but they're being forced to by their family and the court system. And so that actually becomes an issue, a barrier right from the start. And we really try to work with them to get beyond it, to help them see that they truly do have a problem and that, you know, they do need help. In the detection process, we definitely take a look at any past and current use of alcohol, tobacco, and other substances. The lab test is the UAs that I was referring to earlier to screen for the kinds of substances that are in their system currently. You know, when we got clients that are on meth, if we don't get them screened right away, the meth leaves their system within 48 hours. So it's key that we get them drug tested as soon as possible. And a lot of times they refuse, so we actually have to get them up to the ER and get them blood drawn to get a really good toxicology screen on them. And then what are their negative consequences? You know, what keeps happening in their life that has put them in this situation? The classification, we definitely take a look at, you know, any kind of possible DSM diagnoses. Is there some past depression going on? Is there suicidal ideation? Are they having panic attacks? Is there some serious, even more serious things going on that require, you know, some further assessments to happen? The thing that, you know, we take a good look at is we rate their worst period of use. Is that now? Is that like 2 weeks ago? You know, where exactly are we in all of this? And we definitely pull in multiple sources of information. So any kind of collateral information, we try to interview as many of the family as possible. You know, any medical history, any legal history, any you know, work-related, you know, have they been suspended? Have they been fired? All of those types of things. A functional assessment. This is where we try to obtain all the client information from as many available sources just to identify and assess the client's range of need. We also identify the client's strengths, you know, what's going for them right now, what are they hoping to do, because the minute, you know, if they don't have anything going for them, the minute they step out of the, like say they go on a temporary release, if they're under a court order and they're in our social detox, and the minute they get a temporary release and they step out that door, most likely they're back drinking and using, so they end back up again in the system. So it's just a repeating cycle, and so by really identifying their strengths, you help them to understand that they do have a future, that, you know, you get them focused on the future to help them, you know, realize that, you know, they can have a plan. You try to help them understand who their support system is, you know, who do they turn to, and to try to keep a really good, strong relationship going with that. We found a lot of clients have burned bridges everywhere, and so a lot of times they're all alone, nobody to come and support them, nobody to come and help them. And then you identify the client's recovery capital, you know, what is going for them that can help them in the whole recovery process, and really focus in on that and help them understand that they're, you know, that's key in how they are going to move forward in their life. Functional analysis. This is where we identify factors that maintain substance abuse. So where do they live? Are they living in a home that is just nothing but a party house? Explore possible motives. You know, what keeps them drinking? What happens to them that you know, they just have no coping skills, or they're not utilizing their coping skills, or, you know, what are the motives for wanting to continue to drink? A lot of times I've found that, you know, our clients just, how would you put this, are like little kids, and they're very defiant, and you're not going to tell me to quit drinking, you know. And so it becomes a battle of wills, and so the minute, you know, we let that go, then I think they seem to realize that it is their own decision. Then the third thing is you view the identified motives and costs as a working hypothesis, not as a fact. So you know, when you got a hypothesis, you got to understand that facts change, situations change. So meaning that, you know, as you build a treatment plan, you put a timeline on each goal, but what happens is, you know, if you revisit that goal, say in a week to 2 weeks, and you're finding that you're not able to, the client is not able to really meet a particular goal, then rewrite it, you know, redo that goal and allow them to feel that, you know, the treatment plan is flexible, that it is achievable. That's one of the most important things on here. I really think that, you know, not being so structured and so rigid with a treatment plan is going to be one of the biggest successes for the client. So methods of obtaining assessment information. It's really important to interview them face-to-face because you see them, you see their reactions, you see their, you know, their affect. You know, how are they responding to you? Are they emotional? Are they, you know, have no emotion? I mean, are just, you know, it is really key. How do they speak to you? What is their tone? What is their mood? There's so many different levels in a face-to-face interview that's so important in the overall, you know, interpretation of your assessment. So when you do an interview, keep it semi-structured, you know, versus an actual structured interview. Some people really follow a structured interview, and that's okay, but I feel like, you know, by allowing them to be able to speak when they're ready to speak is another level of collateral information that is going to help you make an overall diagnosis and treatment placement for treatment. When you got these self-report assessments, a lot of times they're just paper pencil, and it's really important to try to figure out their level of reading skill, because if you just hand them the pencil and paper and they don't even really understand what's, you know, being asked of them, you're not going to get an accurate response. So another thing is to, some of the self-reports are now computerized, and that to me is awesome, but at the same time you don't get a really good look at how, you know, how they're able to read, if they're able to read. A lot of times I've actually just read the whole assessment to them and tried to get their answer. So we're going to take a look at some of the assessment tools now that we utilize in the field. We have the ASI, and some ASIs are just a paper pencil form, but for those of you who do have AccuCare, it is within AccuCare that the ASI, the questionnaires it's within the AccuCare software package. So, you know, you follow a semi-structured interview when you're assessing, so you definitely look at their medical status, their employment and support, drug use, alcohol use, legal status, their family social status, and then of course the psychiatric. So a lot of times, you know, our chronics are coming to us from a medical facility, meaning that's how far their medical issue has gone. Or they're coming to us, they're referred to us from work because let's say they were drinking on the job or whatever. The legal status, they're referred to us by the federal court system and need to go to treatment before their sentencing date and all of that stuff. So it's like pre-sentencing assessments. Then you got the Comprehensive Drinking Profile, or the CDP. This is a structured intake interview. And basically this one looks at the history and the current status of any kind of drinking problems or anything related in that manner. For example, you know, getting a DUI versus a second DUI versus a third DUI. The consumption and problematic behaviors. You know, when you got somebody that's coming to your department for DUI, you know, our program does a state approved DUI curriculum, and this is for first-time offenders only. And so, you know, if it's beyond that, then you obviously need to start looking at treatment versus just DUI education. Because the consumption and the problematic behaviors, you know, definitely tell you if it's beyond the first offense. You know that there's something serious going on. Then we have the second assessment tool that is out there is the timeline follow back. And this analyzes the patterns, the intensity, the frequency of use, and the connections between use and the significant events that are established. And then there's the inventory of drinking situations, or the IDS. And this assesses situations of heavy drinking. And within that, then it examines 8 categories. So like the negative emotional states, their urges and temptations, the negative physical states, the interpersonal conflict, the positive emotional states, the social pressure to drink, testing personal control, and positive social situations. The Situational Confidence Questionnaire. So this is a self-report assessment, and clients imagine themselves in each situation. So they rate on a scale of 0 to 100, 0 being not confident to 100% being very confident. How likely they will be able to resist the urge to use heavily in that situation. So it's kind of like a case-by-case situation that they give them, you know. And sometimes it does, you know, cause them to stop and really think. And that's actually, I think, you know, a questionnaire that I would really like to use more in my department. Then you got the SASSI, and most of us are more familiar with the SASSI. This is a one-page self-report screening. One thing that I like about this SASSI is that there is the resistance to faking. You know, it identifies individuals who are in denial or deliberately trying to conceal their chemical dependence. That's one thing I do like about the SASSI is, you know, the less they downplay it, the more they are able to, the SASSI gives us the results. Then we got the Global Appraisal of Individual Needs, or the GAIN, and this one has 8 core sections. So we got the background, the substance use, the physical health, the risk behaviors, mental health, environment, legal, and vocational. As you're seeing throughout, you know, these assessment tools, most of them gather a lot of the same kind of information. There's some that actually don't follow, you know, like the one on the heavy drinking use. But otherwise, most of them pretty much use the same kind of information to gather the history and whatnot. Then we're going to go into the DSM-4 TR and the criteria for substance abuse. And you really only need one criteria. So you got the first one, of course, is the recurrent substance use resulting in failure to fulfill major role obligations at work, school, or home. Or you got the recurrent substance-related legal problems, meaning you keep, you know, getting yourself, you know, back in the court system. Recurrent substance use in situations when it is physically hazardous, working and doing very hard physical labor and drinking. Or continued substance use despite having persistent or recurrent social or interpersonal problems. The criteria for substance dependence, we need 3 or more in this category. So first of all, the tolerance, which would be defined by either of the following: a need for markedly increased amounts, so you need more to actually have the impact, you know, the effect of alcohol, or that alcohol is starting to have a diminished effect, meaning you know, before when you would drink a 6-pack, you would get drunk, and then now, you know, a 6-pack doesn't even do anything for you. 2, withdrawal, as manifested by either of the following. You got the characteristic withdrawal syndrome, or the same or closely related substance is taken to relieve or avoid the withdrawal symptoms. So, you know, when people get to that point where they know that they're going to start having withdrawal symptoms, they literally go drink again to stop it from happening. Here's the criteria keeps, it's a continuation here. The substance is often taken in larger amounts over a longer period than was intended. The persistent desire or the unsuccessful efforts to cut down or control substance abuse. And we've had folks say, I'll stop, you know, and so the judge literally says, okay, I'm going to give you this chance, you know, you stop, otherwise you are going to go to treatment. And then they fall off immediately. So, you know right there that they definitely have a hard time even, you know, stopping on their own. A great deal of time is spent in activities necessary to obtain or use the substance or recover from its effects. You know, we do see a lot of people just constantly trying to stay drunk. Important social, occupational, or recreational activities are given up or reduced. So you start seeing people stopping what they used to do, you know, just to maintain their own addiction. The substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem. So, for example, you know, folks who have some very serious medical issues and know that they shouldn't drink because it's going to exacerbate, you know, the medical condition, still continue to drink. And that actually is very, very sad. So the specifiers are with physiological dependence. In order to actually have the physiological dependence be part of the diagnoses, this is where when used with substance dependence is accompanied by evidence of tolerance, which is criteria 1, or withdrawal, which is criterion 2, or without the physiological dependence. So when there's no evidence of tolerance or no evidence of withdrawal. And usually that's when I said it's really important to have the face-to-face interview, that's when you can actually see if they're shaking, if there's, you know, a different color to their skin. You know, there's all different types of physiological things that we take a look at when we're doing the face-to-face interview. So the core specifiers are early full remission, early partial remission, sustained full remission, or sustained partial remission. You know, how are they doing in their process of, you know, the abstinence, you know, stopping to drink? Because it's, you know, a lot of times if they're not in a full controlled environment, you know, it's a lot harder for them to maintain any type of remission. We got the multiaxial assessment. So this is the diagnosis process, and I'm sure a lot of you are familiar with this. So we got Axis 1. This is where we put the clinical disorders or other conditions that may be a focus of clinical attention. This is where we report all the various disorders or conditions in the classification, except for the personality disorders or mental retardation. On Axis 2, obviously we put the personality disorders and the mental retardation. Axis 3 is any general medical condition. So this is where we could put, you know, the diabetes, you know, obesity, any types of things that the client reports. Maybe when you pull in some collateral information, the client doesn't report it, but family members or on a medical history, you'll find other things that are there that the client hasn't reported, which is why it's really important to get that collateral information. Then on Axis 4, you got the psychosocial and the environmental problems. This is where, you know, they're homeless, they don't have any support from their primary support system. They're homeless, you know, they're unemployed, all of those types of things. And then Axis 5 is the GAF, or the Global Assessment of Functioning. This rates their global functioning on a continuum and gives numerical scores of 1 to 100, and with 100 equating superior functioning. Now, normally, if you got somebody who's chronic alcoholic, you know, obviously their numbers are going to be pretty low because they are no longer functioning, meaning they don't have a job. They're usually, you know, homeless, You know, there's a lot of things that go along with that. We're going to go into the ROSC now, which is the Recovery-Oriented Systems of Care. And this is a paradigm shift. And, you know, I really like this. As I came into the field myself, I was very intrigued with this whole process and have tried now very hard to incorporate this into my own treatment program. So it shifts the question from how do we get the client into treatment to how do we support the process of recovery within the person's environment. So for example, when you take a good look at, you know, yeah, we're getting the client into treatment, but, you know, once they come home or while they're in treatment, what are some of the things that we can do to help enhance the recovery, this person's recovery? Like, for example, you know, a lot of them just go right back into the same old environment, which relapse, you know, is so high at that point. So with the ROSC system, it's made us take a look at our whole process and try to incorporate a whole nother level of recovery support and, you know, continuation of the treatment plan as far as, like, you know, from a recovery-oriented systems of care perspective. Now, the treatment agencies are considered one of the many resources for the client, but no one source is more important than the other. I mean, we definitely have to work together. There's various support systems that need to work together in order for this client to be successful. In our department, we meet with all the judges, the prosecutors, both adult and juvenile, the public defenders, mental health, substance abuse, you know, I mean, there's all different levels, and we call that interagency, because all these clients, and DSS, because all these clients come through our system one way or another, and if, you know, if we aren't meeting, they usually tend to fall through the cracks somewhere along the way, and that's what we try to do, is to figure out, you know, where are our gaps in services, and how can we help this client be successful in their process, whether it's trying to get them to reunite with their children, you know, doing a restraining order, keeping them safe, you know, not only from themselves, but, you know, from other folks in their lives. This is what the ROSC support person-centered and self-directed approach looks like. So it's care that builds on the personal responsibility, strengths, and resilience of individuals and families, and of course the community, to achieve their health, wellness, and recovery from a substance-related disorder. So in the circle, obviously, is the individual with their family and the community that they live in. But when we look at the recovery process for all of them, you know, a lot of times it's their health that's been impacted. You know, alcoholism obviously is, you know, their liver is mostly impacted, and it's just to get them to stop drinking in order for their liver to start healing. Maybe get them on an exercise plan. We have access to recovery, the ATR grant, so we are now working with our fitness center and getting fitness passes for our clients to go work out and be part of that whole process. So we are pretty excited about that. And then let's say we got some clients who are in meth. One of the big things that happens to our clients is their teeth are impacted, and to make sure that in their client service route process with us that they see a dentist and get a lot of their teeth, you know, get their teeth worked on, so that they don't get abscesses and, you know, have the impact of all those kind of health issues related to their teeth. We make sure they have full physicals, so we're, you know, we know exactly where they're at in, you know, overall, you know, what's going on with them, because a lot of times these clients have contracted hepatitis C from sharing needles, and possibly even HIV. Here's another level of the ROSC. This is a comprehensive menu of all the services and support that can be combined and readily adjusted to meet their need in their chosen path for recovery. So we work with the vocational rehab, we work with the behavioral health, we work with IHS, and of course, you know, we have the NARCH grant and also the community health program. We have case managers, both IHS and in our own department. You know, with the financial and legal, you know, we try to get them situated with all of that, get them transportation to and from where they need to go. We have a transit service on our reservation, and our program assists with bus transit passes in order for them to come to treatment and any other thing that they have identified. If they want to start college, we really help with that process. This is for them to have the visitation with their children so they can meet the needs of DSS. Within the ROSC, there's a person, it's person-centered and self-directed. So, you know, when you meet with our staff that are, you know, that understand this process, they work with building on the strengths and the resilience of this particular client or patient. So by involving the families and the communities to take some responsibilities for their health and wellness and recovery from mental illness, you know, it's really important to have that family support there because it offers a comprehensive menu of services that can be adjusted to meet the needs of the client or the patient. And it has to be adjusted to the client's pace and recovery process because, you know, we know clients have relapsed in the past and will probably continue to relapse, but the important thing is that they immediately, you know, get back on the road to recovery. And by not shaming them and having them feel like, you know, oh my God, I got to start back to square one or back to, you know, zero, it's really important that you respect them at all levels. The recovery-oriented systems of care encompasses and coordinates the operations of multiple systems. So we try very hard to provide responsive, outcome-driven approaches to their care. So if they identify a particular program that they really want to be part of, you know, then we try very hard to help them get to that program as another level of their care. And it's an ongoing process of system improvement. So you know, we take a good look at what other clients have done and try to incorporate their experiences in those in recovery and with their family members. So, you know, if we find that, you know, a certain program that they went, another client went through worked really well, we encourage other clients and their families to try that program too. We really take a look at the effect of our involvement in the assessment process and that, you know, they are an equal partner in this process. So we try to really explain to them, you know, what is their assessment has, what their assessment has said that tells us, and try to, you know, help them understand how important it is to keep, you know, on their treatment plan and keep moving forward. There's different elements of the recovery-oriented systems of care. So like there's the person-centered, and this is very individualized, and it's very responsive to their own culture and their personal belief systems. And it's definitely community-based, and there's a level of a commitment to peers, and of course the involvement of families and all their friends, anybody that's definitely in their corner. And we try to monitor and outreach to all of them. To get them, you know, reach out to them and make sure that they're doing okay, and is there anything that we can do to continue to help them. And a lot of times when we just reach out to them and try to get them to, you know, come back in and touch base with us, they're actually pretty happy, you know, that we haven't forgot about them, or, you know, that we continue to work with them in so many different ways. Now, the elements of the recovery-oriented systems of care, this is where we take a good look at how cost-effective it is. So, for example, we have, we're very outcome-oriented with the integration of services resulting in no duplication. So, you know, with our access to recovery, we're able to really take a good look at how, you know, if they've had one service before, you know, they cannot utilize that same service, but, you know, we'll try to find something that's comparable. It's definitely competency-based. It's effective use of collaborators and partners. So we definitely try to work with, you know, the court system, and we try to work, because we communicate with the judges and the prosecutors, and we all want the best for our clients, and we all want them to be successful. So we, you know, there is a statewide education and training program that, you know, they can tap into. We take a good look at their continuum of care. This particular program is research-based, and there is flexible funding within this process. We're going to go into the ASAM criteria, which is the level of care. And in the levels of care, you got the early intervention, you got the outpatient treatment, which includes the intensive outpatient treatment. You have the partial hospitalization, and then you got the residential inpatient treatment, which there's 3 different levels there. There's the low intensity, the medium intensity, and then the high intensity. And then you got the medically monitored intensive inpatient program. And those are pretty hard to get into, but, you know, they're there. So within the ASAM criteria, there's 6 different dimensions. And in dimension 1, you got the acute intoxication and or withdrawal. And dimension 2, you got the biomedical conditions and complications. Dimension 3, you got the emotional, behavioral, and cognitive conditions and complications. Dimension 4, you got the readiness to change. Dimension 5, this takes a good look at relapse and continued use or continued problem potential. And dimension 6, the recovery or the living environment. Now, in the first level, which is the level 0.5, or the early intervention, this is where we got one-on-one counseling and educational programs. Now, this is where patients do not meet the criteria for a substance-related disorder. A lot of times it's drug and alcohol education and just maybe some counseling for, you know, some other bigger issues going on in their life. Problems in dimension 1, 2, or 3 are stable, or usually they're being addressed. The level 1, the outpatient treatment, there's different types of therapies that are in that are the individual and the group counseling. There's the motivational enhancement, and there's the opioid substitution therapy, the family therapy, educational groups, occupational and recreational therapy, the psychotherapy, and there's just other kinds of therapies within this. We could be looking at equine therapy, and, you know, other things like that. Dimension 1, outpatient treatment, dimensional admission criteria. So in Dimension 1, there's usually no withdrawal signs or symptoms. Dimension 2, the biomedical concerns are stable. And Dimension 3, you got either A or B and C and D. So A, you got no co-occurring mental disorder symptoms, or the symptoms are mild and stable, meaning there's slight depression going on with some, you know, alcohol abuse. Psychiatric symptoms are mild, but mental health monitoring is needing. So, you know, you have them see a counselor, you know, just to check in on a weekly basis. And then in the Dimension 3C, the mental status doesn't interfere with their understanding and their participation in therapy. And of course, D, there's no risk of harm to self or others. Dimension 4, you got A and B, or C or D. So A, willingness to comply with the treatment plan. B, acknowledges substance abuse and wants help. C, ambivalent about substance use. And D, doesn't recognize that there is a problem with substance abuse or use. And Dimension 5 is able to achieve or maintain abstinence only with support. Now, I know, a lot of this stuff, you guys are reading, but for me, I'm a visual learner as well as, hearing it. So a lot of times when I read it and I'm hearing it, it helps solidify things for me. So Dimension 6, you got A or B or C. So you need 3 admission criteria. So you got the supportive environment for treatment, inadequate support system but willing to obtain a support system, or family is supportive but needs intervention to improve chances of success. And a lot of times this is where we end up, is the family is just as needing treatment or at least therapy in this whole process. So in Dimension 1, there's no withdrawal signs or symptoms. This is the level 2, the intensive outpatient dimensional admission criteria. So no withdrawal signs or symptoms. Dimension 2, biomedical is stable or monitored concurrently, and there's literally no interference. Level 2, Dimension 3, we got A or B criteria. So there's abuse within the family. They have a diagnosis of an emotional, behavioral, or cognitive disorder that requires monitoring. And Dimension 4, there's A or B. They need the need for like a treatment structure and a need for repeated structured interventions. A lot of times this is where the family has done an involuntary commitment order more than once on this particular person. Dimension 5, symptoms intensify and functioning deteriorating at the lower levels of care. So a lot of times when we start out, they start out in outpatient with us, right, at the Four Bands Healing Center. But if they are continuing to relapse and the family saying they're not following through with, their treatment plan and stuff like that, then we have to really take another look at their level of care, and we have to end up putting them in inpatient. Dimension 6, A or B, current environment makes recovery unlikely. So sadly right now our halfway houses are closed, so a lot of our patients are just coming from home or from wherever they're staying. So when they go home every night, the chances of them staying sober decrease because their current social situation is not helping in that recovery process. Now, a clinical evaluation, this is the summary part of an assessment. So we take a look at the assessment process, the assessment instruments, the DSM-4TR diagnostic criteria, and the ASAM levels of care and criteria. And so, I guess this will be where we stop for the questions.
Thank you, Ms. Casillas. If you have any questions, please type them in the Q&A pod at this time. And I do see that Charles has a question. What happens when they don't want to work together, and have you seen that happen?
Are you talking about the different programs?
I'm assuming that's what he is questioning, yes.
Well, we have found, when I first started working at the Four Bands Healing Center, I actually had to go around and make the relationships with the programs. So that way, when it came time for us to truly work together, we had an established relationship. Now, there are still some programs out there that want to remain in their silos, really want to, just do their own thing and stuff like that. But it's really rare when I come across that. I find more and more programs do want to work together. They do want the best for their clientele. And I think by me establishing a relationship early on when I first started at the 4-Bands Healing Center, I think helped to reduce a lot of those conflicts and barriers. I have found, though, that it's the people themselves, not necessarily the program. So sadly, though, when I find that these programs don't want to work together, and I don't want to, you know, really diss anything or anybody, but I find that they usually have either a substance issue themselves or are very codependent and enabling somebody in their family who's really struggling. So I tread lightly when I try to work with other programs. And if I find that they're not able to make that connection right away, I usually try to seek out another person within that department that possibly is capable and willing to work with us.
Okay. Thank you. One more question. What about DSM-5? There are many changes regarding alcohol and drugs.
Yes, there is. At this point, I haven't gone through, I mean, I've gone through some levels of training on it, but I have found even the way they write in the codes, there's so many different things. And for our program, we need to go through the ICD-10 and the DSM-5 training, you know, concurrently, so that way we're able to understand all the changes that are taking place, and that's going to be happening for our program this summer, because they're, you know, it's almost like learning a whole new language again.
Okay. Once again, I would like to thank you, Ms. Casillas, for sharing the presentation with us today.
Is there any more questions?
Please stay online as we close out the webinar so you can be redirected to our survey. If the survey doesn't automatically pop up, you may copy and paste the URL on the closing webinar screen to access the survey. Also watch your email inbox for our follow-up, which will include a link to the recording of this webinar. We hope you will be able to join us again on May 21st for clinical evaluation, treatment planning, and also on excuse me, May 7th for an overview of fetal alcohol spectrum disorders, what we are learning about diagnosis and intervention. Thank you for your time participating in the session today. We hope you've enjoyed the presentation and look forward to hearing your feedback.